Hi everyone, this is the PowerPoint lecture for trauma and stressor-related disorders. I want to give you a little bit of an overview before we get into the specific DSM criteria. So post-traumatic stress disorder, PTSD, is actually included in a new chapter in DSM-5 on trauma and stressor-related disorders. This is a move from DSM-4, which addressed PTSD as an anxiety disorder. So compared to DSM-4, the diagnostic criteria for DSM-5 draw a clearer line when detailing what constitutes a traumatic event. An example of this is sexual assault. It's specifically included, as is a reoccurring exposure that could apply to police officers or first responders. Language stipulating an individual's response to the event, stuff like intense fear, helplessness, or horror, according to DSM-4, has been deleted because that criterion proved to have no utility in predicting the onset of PTSD. DSM-5 pays more attention to the behavioral symptoms that accompany PTSD, and as you will see in a couple minutes, proposes 4 distinct diagnostic clusters instead of 3. These 4 distinct clusters are described as re-experiencing, avoidance, negative cognitions and mood, and arousal. So re-experiencing covers spontaneous memories of the trauma event, recurrent dreams related to it, flashbacks, or other intense or prolonged psychological distress. Avoidance refers to distressing memories, thoughts, feelings, or external reminders of the event. Negative cognitions and mood represent myriad feelings from a persistent and distorted sense of blame of self or others to estrangement from others, or markedly diminished interest in activities to an inability to remember key aspects of the event. Finally, arousal is marked by aggressive, reckless, or self-destructive behavior, sleep disturbances, hypervigilance, or related problems. The DSM-5 emphasizes the flight aspect associated with PTSD, and the criteria of DSM-5 also account for the fight reaction often seen. The number of symptoms that must be identified depends on the cluster, and we're going to go into that in detail. And DSM-5 would require only that a disturbance continue for more than a month and would eliminate the distinction between acute and chronic phases of PTSD. So within the DSM-5 trauma and stress-related disorders, here are the 5 disorders we're going to talk about: reactive attachment disorder, disinhibited social engagement disorder, post-traumatic stress disorder, acute stress disorder, and adjustment disorders. We're only going to go over reactive attachment and disinhibited social engagement very briefly, and we're going to focus on our efforts on PTSD, acute stress, and adjustment disorders. So here's the DSM-5 diagnostic criteria for a reactive attachment disorder. This is a consistent pattern of inhibited, emotionally withdrawn behavior toward adult caregivers manifested by both of the following. So this is seen in children. This is a disorder of children. The child rarely or minimally seeks comfort when distressed, or the child rarely or minimally responds to comfort when distressed. So it's not seeking out comfort, and then when the kid's comforted, they're also not responding to that. A persistent social and emotional disturbance characterized by at least 2 of the following. So minimum social and emotional responsiveness to others, limited positive affect, episodes of unexplained irritability, sadness, or fearfulness that are evident even during non-threatening interactions with adult caregivers. And then the child has experienced a pattern of extremes of insufficient care as evidenced by at least 2 of the following. So the child has experienced social neglect or deprivation in the form of persistent lack of having basic emotional needs for comfort, stimulation, and affection met by caregivers. So I think of like little babies that have failure to thrive. They're not getting their basic needs met. Repeated changes of primary caregivers that limit opportunities to form stable attachments. So kids that are in foster care and that jump around from house to house from the time of infancy. And then rearing in unusual settings that severely limit opportunities to form selective attachments. And then the care in criterion C is presumed to be responsible for the disturbed behavior in criterion A. So it's because the child has been so neglected from its basic needs of emotional needs for comfort that that the child doesn't know how to seek comfort from others and doesn't respond when others try to comfort him or her. The criterion are not met for autism spectrum disorder, which you got to be careful because it can kind of look the same around the social cues for autism spectrum disorder. So that's where a social history is going to be really important for this kind of diagnosis. The disturbance is evident before 5 years of age. So these are little people, little kids. And the child has a developmental age of at least 9 months. So the child's over 9 months old and younger than 5 years old. And then when you diagnose reactive attachment disorder, you have to specify if it's persistent or severe. Epidemiology of reactive attachment disorder. So the prevalence is unknown, but it's seen relatively rarely in clinical settings. So this isn't a diagnosis that we see a lot of. The disorder has been found in young children exposed to severe neglect. So I think about impoverished conditions or, war-torn conditions. However, even in these populations, the disorder is uncommon, occurring in less than 10% of children. Clinical features manifest between the ages of 9 months and 5 years, like we said. It is unclear if it occurs in older children, and if so, how presentation differs. So what does it look like in an older child? And then it often co-occurs with developmental delays in cognition, language, and then medical conditions such as severe malnutrition because of severe neglect and depressive symptoms. So disinhibited social engagement disorder, here are the DSM-5 diagnostic criteria for this. A pattern of behavior in which a child actively approaches and interacts with unfamiliar adults and exhibits at least two of the following. So this is the opposite of reactive attachment disorder. So reduced or absent reticence in approaching and interacting with unfamiliar adults, overly familiar verbal or physical behavior that is not consistent with culturally sanctioned and with age-appropriate boundaries, diminished or absent checking back with an adult caregiver after venturing away, even in unfamiliar settings. So if you think about attachment theory and you think about the strange situation, the experiment, the strange situation, when the baby looks at the caregiver for help or looks at the caregiver when they start exploring, these are kids that don't do that. They don't check in with their caregivers. And then the willingness to go off with an unfamiliar adult with minimal or no hesitation. The behaviors in criterion A are not limited to impulsivity, but include socially disinhibited behaviors, and the child has experienced a pattern of extremes of insufficient care. So social neglect or deprivation, lack of having basic emotional needs for comfort, stimulation, and affection met by their caregivers, repeated changes in primary caregivers, and then rearing in unusual settings to really limit opportunities to form selective attachments. So kind of the same thing. You think about kids in foster care, you think about kids that are born into poverty. I always think about kids that are born incarcerated and haven't had the ability or haven't been able to securely attach with their caregivers. So the care in criterion C is presumed to be responsible for the disturbed behavior in criteria A, just like in reactive attachment disorder. And then the child has a developmental age of at least 9 months old. I did have one girl on my caseload that was diagnosed with disinhibited social engagement disorder. So I will be sure to tell you all about her in class. Epidemiology, just like reactive attachment disorder, the prevalence is unknown. The disorder appears to be rare, occurring in a minority of children, even those that have been severely neglected and subsequently placed in foster care or raised in institutions. And in those high-risk populations, so kids that are in foster care and kids that are raised in institutions, the condition occurs in about 20% of children. Why do you think, here's an opportunity to write something down. Why do you think for reactive attachment disorder and disinhibited social engagement disorder that the prevalence is unknown? It's probably a good question. Why aren't we able to know what the prevalence of this is? Take a second and write that down. So for kids with disinhibited social engagement disorder, conditions of social neglect are often present in the first months of life in children diagnosed with this disorder. So again, I think about failure to thrive in little babies. There is no evidence that neglect beginning after 2 years is associated with manifestations of the disorder. So it's really infant, that 0 to 2 year marker. When the disorder persists into middle childhood, clinical features manifest as verbal and physical overfamiliarity as well as inauthentic expressions of emotions. In the case that I had and the little girl that I had, that was exactly what happened. Peer relationships are most affected in adolescence, obviously, with both indiscriminate behavior and conflicts apparent. And the disorder has not been described in adults. My guess is that it looks like something else in adults, and we can talk about that. And the comorbidity with cognitive delays, language delays, and ADHD. So post-traumatic stress disorder, PTSD, here are the DSM-5 diagnostic criteria. Like I said earlier, PTSD in the DSM-4 was listed as an anxiety disorder, and it now has a chapter all of its own. It's important to note that these criteria apply to adults, adolescents, and children older than 6 years of age. We are going to talk about another new section that has been added to DSM-5, which is PTSD in children under 6 years of age. But for this section, this just applies to individuals older than 6 years of age. There are a lot of diagnostic criteria, so please bear with me as we go through them. So the following criteria, this is what needs to happen. Exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. So directly experiencing the traumatic event, it happened to you, or witnessing in person the event as it occurred to others, so it happened to somebody else and I saw it. Learning that the traumatic event occurred to a close family member or close friend. In cases of actual or threatened death of a family member or friend, the event must have been violent or accidental. And then experiencing repeated or extreme exposure to aversive details of the traumatic event. And there's a note for this criterion that it does not apply to exposure through electronic media, television, movies, or pictures unless this exposure is work-related, which I think is really interesting, and we can talk about that. So, in addition to experiencing the event or exposure to the event, you also have to have presence of one or the more intrusive symptoms associated with a traumatic event beginning after the event occurred. So recurrent, involuntary, and intrusive distressing memories of the traumatic event. So this is like intrusive thoughts, like you're just kind of going about your day and then you get all these intrusive thoughts around the event. In children older than 6 years of age, repetitive play may occur in which themes or aspects of the traumatic event are expressed. So if you're working with kids, it's important to pay attention to what's going on in their play. Recurrent distressing dreams in which the content and or affect of the dream are related to the traumatic event. So in children, there may be frightening dreams without recognizable content, and I feel like that's true in adults as well. But sometimes sometimes you have dreams and you get the same feelings as you did during the event, but you might not recognize the content. Dissociative reactions in which the individual feels or acts as if the traumatic event were reoccurring. In children, trauma-specific reenactment may occur in play. So this is kind of like dissociating is kind of like you're watching yourself outside of your body. So this would be like you're watching yourself, you're watching the event happen over and over and over again. Then intense or prolonged psychological distress at exposure to internal or external cues that symbolize or resemble an aspect of the traumatic event. We call those trauma triggers. And then, let's see, marked psychological reactions. I just said that. I'm sorry. Trauma triggers. And then persistent avoidance of stimuli associated with traumatic events. So this happened to me, and now I am totally going to avoid anything that has to do with that traumatic event. And that is evidenced by one of the following: avoidance of or efforts to avoid the distressing memories, thoughts, or feelings about or closely associated with the traumatic events, and efforts to avoid external reminders that arouse distressing memories. So not only am I going to avoid the event itself, I'm going to avoid anything that triggers me thinking about that event as well. Oh, this is a very small slide. Negative alterations in cognition and mood associated with traumatic events. So the inability to remember an important aspect of the traumatic event. Oftentimes I'll get clients who will say to me, I have no idea. We will talk about the event, we'll go through the trauma narrative, and there's some things that they just can't remember. Persistent and exaggerated negative beliefs or expectations about oneself, others, or the world. distorted cognitions about the cause or consequences of the traumatic event that lead the individual to blame himself, herself, or others. A lot of times when I work with children who have trauma at the hands of their parents, through sexual abuse or physical abuse, domestic violence, that kind of stuff, a lot of the work is around those cognitive distortions, and really helping the client to realize that what happened was not their fault. Persistent negative emotional state, so that can look like depressed mood, that can look like irritability, anything that's persistently negative. Markedly diminished interest or participation in significant activities, and like we said on the slide before that, typically that's because of this fear that there's going to be trauma triggers and you're going to have distressing memories of the event that occurred. Feelings of detachment or estrangement from others, and I think that can manifest in nobody understands what I'm going through, nobody knows how hard this is, or I'm afraid that I'm going to have distressing memories or events again, so I'm just going to isolate myself from others. And then the persistent inability to experience positive emotions. So again, that plays into the depressed mood. And then marked alterations in arousal and reactivity associated with a traumatic event, beginning or worsening after the event occurred, as evidenced by 2 or more of the following. Irritable behavior and angry outbursts, typically expressed as verbal or physical aggression toward people or actions. I have a client that I work with, and she's young, she's 11, and she got into an argument with her great-grandmother, and her great-grandmother said to her, "Why can't you just be normal?" And that was a total trauma trigger for her, in terms of she believed that her grandmother thought that she was crazy, quote unquote, and she had like a really severe angry outburst. So that's what happened with her. But we're going to talk about her in class a lot too. Reckless or self-destructive behavior, hypervigilance, exaggerated startle response, problems with concentration, and sleep disturbance. And then the duration of the disturbance is more than 1 month, so duration is very important. That's what's going to distinguish PTSD from another disorder we're going to talk about in a couple minutes. It causes clinically significant distress or impairment in school, occupational, or other areas of functioning, and it's not attributable to the psychological effects of a substance. So when you give a diagnosis of PTSD, there are some specifiers. So you are going to specify if it is with dissociative symptoms. Let's see. The individual experiences persistent or recurrent symptoms of either of the following. So depersonalization, which is this recurrent experience of feeling detached from, as if you were outside your own body, as if you're observing what happened. Or derealization, persistent or recurrent experiences of unreality of surroundings. So like I don't even understand where I am right now. And then you would specify with delayed expression if the full diagnostic criteria are not met until at least 6 months after the event. So there's that duration piece again. So here is PTSD for children 6 years and under. This was newly added to DSM-5 as well. And exposure to traumatic events in children is not rare, and it is estimated that more than 1 in 4 young children will experience at least one traumatic event before adulthood. That's a huge number. In a representative study of children in the United States, this data is a little bit old, but between 2002 and 2003, only 29% of children had not been exposed to a traumatic event. My guess is that number is higher now, or lower actually, that more children have been exposed to a traumatic event. Until recently, many believed that young children had only temporary reactions to life-threatening experiences, quickly putting the experiences behind them. But current research has established that very young children unquestionably develop symptoms of PTSD, such as re-experiencing, avoidance, numbing, and hyperarousal, although detecting the presence of symptoms in preverbal children may be more difficult than in older children and adults. PTSD is prevalent in children who experience war-related stressors, criminal and/or deliberate victimization, and accidents or disasters. Approximately 1/3 of children will develop PTSD after road traffic accidents and natural disasters. It is also estimated that 34% of urban youth exposed to community violence have been reported to develop PTSD. Children exposed to maltreatment have been shown to have high rates of PTSD at approximately 36%. And additionally, researchers have found that maternal PTSD may be a salient risk factor for child PTSD, and intergenerational PTSD may be related to biological factors conferred in utero, which is just fascinating. Research has demonstrated that developmentally sensitive assessment of symptoms after trauma may be more valid than were represented in the DSM-4 criteria in very young children, because symptoms of PTSD may differ substantially between children and adults. It looks different. So this edition of the DSM includes specific guidelines for diagnosing PTSD in children under 6. So these are the criteria for this diagnosis. So in children 6 years or younger, exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. So directly experiencing the traumatic event themselves, or witnessing in person the events as it occurred to others, especially with their primary caregivers. A lot of times kids witness domestic violence. They're witness to physical abuse. They might be victims of sexual abuse under the age of 6. So these are kids that would have a diagnosis or could be eligible for a diagnosis for PTSD. So witnessing does not include events that are witnessed only in electronic media, television, movie, or pictures. And then learning that the traumatic event occurred to a parent or a caregiving figure. So kids under the age of 6, just by learning that a traumatic event occurred to their caregiver, can develop PTSD. Here's some more of the diagnostic criteria. So presence of one or more of the following intrusion symptoms. So intrusive thoughts again, recurrent, involuntary, intrusive, distressing memories of the traumatic event. Spontaneous and intrusive memories may not necessarily appear distressing and may be expressed as play reenactments. And with kids under the age of 6, you're primarily going to use play therapy just as a tool, as a very large tool in your treatment, and watching the themes that arise through their play will really help you in terms of treating the PTSD. Reoccurrent distressing dreams in which the content and or affect of the dream are related to the traumatic event. So definitely talking to kids about having nightmares, what the nightmares are about, going into detail to describe the nightmares is very important. Dissociative reactions in which the child feels or acts as if the traumatic event were reoccurring. So again, you could see this during their play. I'm going to show you a video of a little boy, a 5-year-old, who had a diagnosis of PTSD from sexual abuse, and he used to play it out all the time in the playroom. So I'll show you a video of that. Intense or prolonged psychological distress at exposure to internal or external cues that symbolize or resemble an aspect of the traumatic event. So these look like trauma triggers, or these are trauma triggers again. We're going to talk a lot about trauma triggers in class and what the implications are for trauma triggers, specifically in little kids, but in all people. And then marked physiological reactions to reminders of the traumatic event. So physiological reactions, which means my heart is beating, or my heart is racing, I'm starting to sweat. In little kids, it's going to be somatic stuff. My stomach hurts, my head hurts. So physiological reactions to those trauma triggers. And then one or more of the following symptoms representing either persistent avoidance of stimuli associated with a traumatic event or negative alterations in cognition. So your thinking is distorted and your mood is probably depressed or irritated associated with the traumatic event must be present beginning after the events or worsening after the events. So this is a change in behavior. We talked about ADHD being born with it, it's biological. This is a marked change in behavior. So an event occurs, the child's behavior is different, and then all these trauma triggers come into play, and the kids, everything's coming out sideways on the kid in terms of emotions and feelings, because related back to the traumatic event. So persistent avoidance of stimuli, avoidance or efforts to avoid activities, places, or physical reminders that arouse recollections of the traumatic event, or avoidance of or efforts to avoid people, conversations, or interpersonal situations that arouse recollections of the traumatic event. So if a traumatic event, if it's domestic violence and the kid's parents are divorced, they are going to do everything in their power not to have to go to that parent's house. Or if something happened in school, if there was a crisis in school and they have PTSD, they are not going to want to go to school. If they were in a car accident, sometimes little kids don't want to get back into the car. Negative alterations in cognition. So these are those distortions in their thinking. So increased frequency of negative emotional states. Marked diminished interest and participation in significant activities, including constriction of play. So this is a change too. So all of a sudden, my little 4, 5, 6-year-old loved to play and loved to go out and do things, and now they don't want to. Socially withdrawn behavior and persistent reduction in expression of positive emotions. Sometimes PTSD in kids under the age of 6 can look like separation anxiety. But this is something you have to remember, that it occurs after a traumatic event and it's a change in behavior. Alterations in arousal and reactivity associated with the traumatic events, beginning or worsening after the traumatic events occurred. So irritable behavior, angry outbursts, hypervigilance, that's looking around all the time, I never feel safe, exaggerated startle response, problems with concentration, sleep disturbances. The duration of the disturbance, again, is more than 1 month. The duration is important. And it causes clinically significant distress in relationships with parents, siblings, peers, or other caregivers, or with school behavior. And it's not attributable to the physiological effects of a substance or another medical condition. So this isn't a side effect of an antibiotic that a kid is taking, and it's not because something is going on medically. With dissociative symptoms, the individual symptoms meet the criteria for PTSD, and in addition, in response to the stressor, they experience persistent or recurring symptoms of either of the following. So the same thing, either that depersonalization, I feel like I'm outside of my body, or that realization that what is going on around me is not reality. And then you could specify again if it's with delayed expression, if it's not met until 6 months after the event has occurred. So epidemiology, the lifetime prevalence of PTSD is 6.8% to 7.8%. This is back to all PTSD, not just PTSD in kids under 6. The gender differences, the prevalence is nearly 3 times as high among women than men. So there's another thing that I want you to take a second and write down. Why do you think the prevalence of PTSD is so much higher in women than it is in men? And then many more people experience traumas than develop PTSD. So not everybody, and this is really important as a clinician to know, that not everybody that experiences a trauma will develop PTSD. The most common traumas, 51% of women and 60% of men, which is different from the other gender difference number. I'll have to look into that. So most common traumas experienced overall for both genders is motor vehicle accidents, 23% lifetime prevalence. For women, the most common traumas are rape, molestation, neglect, and physical abuse. For men, it's more physical attacks, threatened with a weapon, accidents, and witnessing the trauma itself. And then the most common traumas in PTSD that occur for men are war or seeing someone killed, and for women are rape and sexual molestation. Predictors of developing PTSD, there's some historical variables to look at. So a family history of psychopathology, a pre-existing psychopathology, so typically a depression or an anxiety disorder, childhood trauma, if you experience childhood trauma, and then low IQ is a higher predictor of developing PTSD. The trauma variables for developing PTSD is the duration of the trauma, how long did it last, your perception of life threat, how threatened, how unsafe did you feel, did you think you were going to die, and the proximity, how close to the trauma were you. Processing occurring during the trauma is also a predictor. So if during the trauma, I think about this when you think about victims of rape, sometimes they talk about having this dissociative experience where they feel like they leave their body. So that's a predictor of developing PTSD. and then extreme fear, helplessness, and horror. So those really like extreme feelings are a predictor of developing PTSD. And then after the trauma, social support and life stress. So do I have somebody that I can talk to about this? Do I have support around this? And what else is going on in my life? Am I able to deal with this kind of trauma effectively? And then there is some comorbidity with depression, but substance abuse is the most common. So maybe write that down too. Why do you think substance abuse is the most common comorbid diagnosis with PTSD? So treatment for PTSD, and you guys see your names next to the treatment. So what I want you to do is I want you to look up the treatment that your name is next to, and we will talk about these in class. So prolonged exposure is Stella, cognitive processing therapy is Chrissy, stress inoculation training is Vicky, EMDR is Tyler, and TFCBT is Sylvia. So look up those treatments and just give us a brief summary and overview of what you find. So we will move on to acute stress disorder. The difference between acute stress disorder and PTSD is going to be the duration criteria. So again, in acute stress disorder, it's exposure to actual or threatened death, directly experiencing the trauma, witnessing in person as it occurred to others, learning the event happened to a close family member or close friend, and experiencing repeated or extreme exposure to aversive details of traumatic events. Same intrusion symptoms as PTSD, recurrent involuntary intrusive thinking, recurrent distressing, frightening dreams, dissociative reactions where I feel like I'm outside my body, intense or prolonged psychological distress or reactions in response to internal or external cues, so trauma triggers. Negative mood, so persistent inability to experience positive emotions. Dissociative symptoms, an altered sense of the reality of one's surroundings or oneself. The inability to remember an important aspect of the traumatic event. And then avoidance symptoms, so avoiding distressing memories or thoughts or avoiding any trauma triggers or reminders around those distressing images or thoughts or memories. Your arousal symptoms, your sleep disturbance, irritable behavior and angry outbursts, hypervigilance, problems with concentration, exaggerated startle response. So here is the difference because the criteria are basically the same. The difference is the duration of the disturbance is 3 days to 1 month after the trauma exposure. So from 3 days, if a client comes to you and their trauma was 3 days to 1 month ago, then you would give them a diagnosis of acute distress disorder. Anything past a month and out, would be PTSD. Epidemiology of acute distress disorder. The prevalence in U.S. and non-U.S. populations is identified in less than 20% of the cases following a traumatic event that do not involve interpersonal assault. 13% to 21% of motor vehicle accidents, 14% of mild traumatic brain injury, 19% of assault, 10% of severe burns, 6 to 12% of industrial accidents, and 20 to 50% are reported following interpersonal traumatic events, including assault, rape, and witnessing a mass shooting. Acute stress disorder cannot be diagnosed until 3 days after a traumatic event and progresses to PTSD after 1 month. Approximately half of individuals eventually develop PTSD. So that's not a great statistic. The gender, more prevalent among females and males again. And then 2 risk factors that were identified in the DSM are temperamental risk factors, so a prior mental disorder, a high level of negative affect, a greater perceived severity of the traumatic event, and an avoidant coping style. So those are things that are part of your temperament that might be a predictor of an acute stress disorder. Or environmental, so exposure to traumatic event, and then a history of prior trauma might up your chances for having an acute stress disorder. So, last but not least in this section, this is a very long section, are adjustment disorders. So adjustment disorders are something that in my private practice I do diagnose quite a bit. This is something that I do see quite a bit. Adjustment disorders are a group of conditions that can occur when you have difficulty coping with a stressful life event. These can include the death of a loved one, a relationship issue, or being fired from work. While everybody encounters stress, some people have trouble handling certain stressors. So the inability to adjust to the stressful event can cause one or more severe psychological symptoms that sometimes and can sometimes even cause physical symptoms. So when that happens and the client comes into your office, here is the DSM-5 diagnostic criteria that you are looking at for an adjustment disorder. So the development of an emotional or behavioral symptom in response to an identifiable stressor occurring within 3 months of the onset of the stressor. So I get a lot of clients that go through a divorce and then present with depressed mood, or whose parents get divorced. The kid's parents get divorced, and then they present with anxiety. So adjustment disorders are pretty common. The symptoms or behaviors are clinically significant as evidenced by one or both of the following. So marked distress that is out of proportion to the severity or intensity of the distressor, taking into account the external context and the cultural factors that might influence symptom severity and presentation. So something happens in somebody's life, and then their distress to it is they need help. It's risen to the level that they are coming to see you, so they obviously need help. And it's causing significant impairment in social, occupational, or other areas of functioning. The stress-related disturbance does not meet the criteria for another mental disorder and is not merely an exacerbation of a pre-existing mental disorder. So this is a change. An adjustment disorder is something is different. Something feels different. The symptoms do not represent normal bereavement. So thinking back to depression, when we talked about bereavement, if you have loss of a loved one and you're grieving, you would probably not be diagnosed with an adjustment disorder. And once the stressor or its consequences have terminated, the symptoms do not persist for more than an additional 6 months. So this is short term. It's a short-term period of time. When you diagnose an adjustment disorder, you need to specify what the client is presenting with. So adjustment disorders, they can present with depressed mood. So low mood, tearfulness, or feelings of hopelessness are predominant. With anxiety, so thinking back to our anxiety disorders talk, nervousness, worry, jitteriness, or separation anxiety is predominant. With mixed anxiety and depressed mood, so a combination of both. With disturbance of conduct, that's typically with adolescents, you'll see that. So disturbance of conduct is predominant. With mixed disturbance of emotions and conduct, so emotional symptoms. Wow, I got typos all over this. I'm sorry. So I have depressed mood and I have a disturbance in conduct. So I'm sad and I'm skipping school all the time and telling my teachers to F off, and my parents just got divorced. And then unspecified. So 4 maladaptive reactions that are not classifiable as one of the specific subtypes of the adjustment disorder. Last slide. Epidemiology of adjustment disorders. So the prevalence, 5% to 20% of individuals in outpatient mental health treatment. So that's going to be a lot of your clients. 20% of your individuals, could present with an adjustment disorder. It's the most common diagnoses in hospital psychiatric consultation settings. So 50% of people. So again, very common. The risk factors of developing an adjustment disorder, environmental factors. So individuals from disadvantaged life circumstances experience a high rate of stressors and may be a greater risk. And then the comorbidity, this can accompany most any mental disorder and any medical disorder. So again, very, very prevalent. So we will talk about, we'll go more into depth with treatment, especially with the information that you guys have. And I have a lot of videos to show you on trauma, and we will talk about it in class. I'm also going to post on here the slideshow for dissociative disorders as well.